بسم الله الرحمن الرحيم. السلام عليكم. اليوم محاضرتنا راح تكون عن الأوكيولار تروما في سلسلة محاضرات مساق العيون لطلاب كلية الطب في الجامعة الهاشمية. راح نحكي اليوم بشكل سريع عن different types of ocular trauma and how to manage each type. بالبداية خلينا نحكي إنه the ocular injury to the eye can result in immediate or delayed loss of vision, or it can result in significant disfigurement with great social and psychological impacts. فالمرضى بعد إصابات العيون معرضين إنهم يخسروا نظرهم، معرضين إنه يصير في تشوه، معرضين إنهم يضطروا يغيروا شغلهم أو يفقدوا وظائفهم بسبب هاي الإصابات. عشان هيك recognition of the nature and extent of injury must be made all the time prior to further damage اللي ممكن يصير واحنا نسميه secondary damage ناتج عن loss of ocular contents, infection, subsequent glaucoma or retinal detachment. فالتروما itself ممكن تكون trivial لكن ممكن يتبعها secondary damage هو اللي يمكن يعمل لي المشاكل. لذلك proper follow-up and treatment for the initial trauma and the post-trauma complications is essential. سريعا نحكي عن الاسسمنت. Assessment is the same as in all ocular conditions. لازم نركز على الهيستوري. It's essential to obtain accurate history regarding the mechanism of injury سواء كانت blunt, penetrating, chemical exposure, time and place, and we should ask about specific symptoms such as loss of vision or double vision. الexamination القاعدة العامة لازم نكون gentle. Always be gentle assuming that there is an open globe injury. We don't want to cause more damage. So we should be gentle. We should look for asymmetry of the eyes, inspect the eyelids for any lacerations, any swelling, any foreign bodies, loss of tissues through the eyelids. We should record the best correct visual acuity. This is very important. We should examine the pupillary reactions, and that will tell us about nerve injury or retinal damage, especially when we look for the afferent pupillary defect. Measuring the IOP. Sometimes you cannot measure the IOP using Goldman or Tonopin in a traumatized eye, but simply digitally feeling the eye, whether it is soft or hard, will be enough in most of the time. Then we should proceed with proper examination of the anterior and posterior segment examination as far as we can see, depending on the nature and extent of injury. Always remember in managing patients with eye injury that we should look for asymmetry. Ocular symmetry is normal. Ocular asymmetry is abnormal. This is very important. And always remember also that mistakes are made in medicine by not looking rather than by not knowing. Whenever we suspect هاي قاعدة ABC, whenever we suspect a rupture globe at any point of the examination, we should stop manipulating the eye, protect it, refer to proper ophthalmology service. It's a good idea to tell the patient that you may have surgery, so please don't eat. Put the patient on PO. If I am in the hospital setting, I may start intravenous antibiotic. Make sure that tetanus prophylaxis is up to date. Certain cases when we suspect orbital fracture, orbital wall fracture, or intraocular foreign bodies, we need to do CT of the orbit. What are the types of ocular injury? Different degrees. Spectrum is wide. It ranges from minor ocular injury, chemical injury, blunt injury, orbital and lens injury, then perforating with or without intraocular foreign body injury. Quick statements about the minor trauma. Conjunctival foreign body is common and minor trauma to the eye, but it is very annoying to the patient. The patient will come with pain, photophobia, foreign body sensation, inability to open the eye, lacrimation. And when you look at the eye, you should avert, whenever you have foreign body sensation, you should avert the upper eyelid. There is no ocular examination is complete, until the upper eyelid is averted and inspected. So because the conjunctival foreign bodies, they tend to lodge in the upper tarsal conjunctiva. Sometimes linear epithelial corneal streaks may lead us to the suspicion of upper conjunctival foreign body. Whenever you see that conjunctival foreign body, you remove it with cotton tip or whatever instrument you have. Then everything will be fine. You may give the patient lubricating eye drops or eye ointment for a few days, and that's it. Corneal foreign body is another mechanism of injury. It happens in patients who work with welding or cutting special material, such as cutting iron or hammering nails, and different mechanisms. Foreign bodies might be metallic or non-metallic on the corneal surface. They may be deep or superficial. Superficial foreign bodies can be removed easily with disposable needles or cotton tip applicators. But deep foreign bodies need to be removed by a specialized ophthalmologist under slit lamp examination. And whenever we suspect full thickness corneal penetration, it's better to be removed under the microscope while we are prepared to go for surgery if needed at the same time. After the removal of the foreign body, there will be a residual abrasion, so we may give the patient for a few days topical antibiotics and non-steroidal medications. Patching is not necessary all the time. And it's better to follow up the patient until there is complete healing. Corneal abrasion or flash burns from UV burns can cause also severe pain. It is self-limiting and it can spontaneously heal. Theoretically speaking, it increases the risk of infection in those patients. Whenever you have a patient with corneal abrasion, the patient will be unable to open the eyelids, very severely photophobic with severe pain. When we apply topical anesthesia, it's like magic for the patient. So he will be able to open the eye and you can examine the patient comfortably, and you can put fluorescein stain to see the extent of the abrasion. Always avert the upper eyelid to check for the subtarsal foreign body. However, we are not allowed to give the patient a local anesthetic eye drops to use at home. This will result in a significant delay of healing and probably will complicate that corneal abrasion and result in severe corneal ulceration. This is a slit lamp picture with the fluorescein staining. You can see the fluorescein filling the area that the abrasion. Fluorescein is a water-soluble stain, so that abrasion is usually filled with the tear film. So fluorescein will go there and fill that defect. So when we look at the fluorescein using the cobalt blue light, we'll see the abrasion very well localized. The second type of ocular injury is the chemical injury, and we have both chemicals, the alkali and the acid. Alkali burns are twice as common as the acid burns because they are more widely used at home and in different industries. The most common alkalis are the ammonia, sodium hydroxide, and lime, while the acids we have the sulfuric, hydrofluoric, acetic, chromic, and hydrochloric acid. The acid tends to coagulate proteins, and that will make the acid burns less penetrating to the eye, but the alkali tends to denature the proteins and allow for further penetration and more extensive damage to the eye. Chemical burn is the only type of eye injury that requires immediate treatment, even without taking history, proper history, and performing full examination. And the immediate treatment is by copious irrigation. So we ask the patient we put the patient in a couch, we bring the normal saline bag or ringer lactate bag, open the IV set, and start irrigating the eyelid of the patient, double everting the eyelid to remove whatever residual particles there of the offending material. We continuously irrigate until we are sure that the pH is normalized. At least 30 minutes. Usually we use 1 or 2 liters of normal saline to properly irrigate the eye that has that type of injury. And after we do the proper irrigation, we may now come and take good history, do proper examination, assessing the extent of the injury, the degree of ischemia, the degree of penetration of that chemical. For mild injuries, they usually are treated with short course of topical steroids, cycloplegic agents to reduce the pain, and with prophylactic antibiotics for a few days. Generally speaking, the main aim of the treatment for severe burns is to reduce the inflammation, promote the recovery, and prevent sterile epithelial corneal ulceration, and also reduce the scarring that will happen after chemical injury. This is a picture of the cornea after being exposed to chemical, and you can see that there is complete de-epithelialization of the cornea. This is also a patient with the chemical burn, and you can see opacification of the cornea secondary to damage to the corneal epithelium and limbal stem cells of the cornea. One of the known complications of chemical burns are conjunctival scarring. So you can see here that there are scars between and adhesions between the bulbar conjunctiva and the tarsal conjunctiva. It's called symblepharon. And here also a scar between the eyelid and the conjunctiva, also extending into the cornea. This is symblepharon also, and this is also can be called pseudopterygium because it looks like pterygium. And these scars are significant cause of disfigurement, dysfunction, discomfort for the patient, and they require later on specific surgery. Let's now talk about a blunt injury. A blunt injury يعني الإصابة بالضربات غير الحادة، مثلا زي التعرض للضرب بالكرة أو اللكمة أو أي شيء ما بيشمل التعرض لأداة حادة. It is common. Sometimes the extent of injury may be hidden behind the extensive lid swelling or the black eye. We should examine the eye properly, looking for different spectrum of possible intraocular injury after blunt trauma, such as HYPHEMA, retinal detachment, optic nerve injury, and choroidal injury. And always, and this is a rule of thumb in blunt injury, we should rule out rupture globe all the time. The extent of the trauma in blunt injury depends on the size of the object. So if we have a large object, such as a running tennis ball, for example, this will hit the orbital margin, the upper and the lower orbital margin. Probably this will minimize the ocular injury and maximize the orbital injury. If we are dealing with a squash ball, which is a smaller ball, then this will lead to direct globe injury with the subsequent complications. So the size of the object will give us an idea or clue about the extent of the globe injury. Let's speak quickly about the possible complications of blunt injury. The subconjunctival hemorrhage is benign and self-limited, can follow trivial trauma. Usually there is no treatment, but if it is extensive, such as this picture, then we should be aware of possibility of rupture globe. So if we have such bullous subconjunctival hemorrhage after a blunt trauma, we should suspect the presence of rupture globe. This is another example of subconjunctival hemorrhage. Usually it resolves within 1 to 2 weeks without specific treatment. This is another example. The second possible complication is HYPHEMA, which is defined as collection of blood in the anterior chamber, and it appears as a blood level or filling the part or the whole anterior chamber. Presence of HYPHEMA in the anterior chamber may result in complications such as corneal staining and secondary glaucoma. Patients may bleed secondary to injury to the iris root or iris blood vessels. There might be initial bleeding, but after a few days also the patient may re-bleed again. If we have a large size clot in the anterior chamber, the probability of having complications is higher. So we need to admit the patient or do surgical evacuation to minimize the risk of complications. HYPHEMA sometimes, which results from blunt surgery, may hide behind it more extensive retinal complications such as retinal hemorrhages, dialysis break, or retinal detachment or commotio retini. How to treat HYPHEMA? Usually conservative. Sometimes we need to hospitalize the patient. We may give the patient steroid eye drops with cycloplegics. Anti-glaucoma medications may be used if the IOP is high. Surgical drainage is indicated in certain situations. This is an example of HYPHEMA, which with a blood level covering more than 1/3 of the anterior chamber. This is also another example of HYPHEMA with the blood level in the anterior chamber. These are the retinal complications that may occur secondary to blunt trauma. This is retinal dialysis, where the retina will be detached from its insertion at the retinal base, causing retinal dialysis and retinal detachment. This is a traumatic macular hole. This is choroidal injury. We call it choroidal rupture. And this is the scar that occurs after choroidal rupture. This is whitening of the retina with some hemorrhages here. This is called commotio retini. It is our Berlin's edema. It is intraretinal edema secondary to blunt trauma. And usually this is self-limited. Takes some time, few days to few weeks until it resolves. If it involves the macula, then there might be residual visual loss after resolution. Otherwise, the edema resolves. It may leave some retinal pigment epithelium changes after the resolution. We should always be aware that whenever we have such extensive retinal injury, we should make sure that we don't have retinal dialysis or retinal breaks. Let's now talk about the open globe injuries, including the rupture globe, ocular laceration, penetrating and perforating trauma. Rupture globe may result from severe blunt trauma, and usually the rupture is anterior, near the limbus, or at the insertion of the recti. Sometimes, occasionally, the rupture is in a posterior or occult, with little damage to the anterior segment. So whenever we suspect that there is rupture globe, we should treat as such. How do we suspect rupture globe? By changing asymmetrical anterior chamber depth, asymmetry in the intraocular pressure. Those will give us a clue that there is probable rupture globe. These pictures are examples of rupture globe secondary to blunt trauma. This is scleral laceration with exposure of the uveal tissue. Here, this is a picture of the anterior segment. This is the limbus. This is part of the cornea. It looks like there's an extensive corneal scleral open injury with prolapse of the iris and uveal tissue. Here is the similar picture. These are the eyelids, and this is such an extensive open globe injury with extrusion of all the ocular contents. So rupture globe varies from small lacerations that can be repaired with minimal visual sequelae to loss of vision or to loss of the eye as a whole. The other type of open globe injury are the lacerations, the corneal lacerations or corneoscleral lacerations. They are recognized by the presence of iris prolapse or the uveal tissue prolapse, pupillary distortion, bulging of the iris through the cornea. Usually there is shallow or flat anterior chamber and there might be associated HYPHEMA. If the laceration involves the sclera, then there is increased risk of retinal and lens damage with vitreous loss, vitreous hemorrhage, extrusion of the uveal tissue and the choroidal tissue. If we have laceration through the eyelids, that will result or that make us suspicious of scleral laceration in addition to the eyelid laceration. So this is a perforating corneal laceration. This is the corneal defect with some iris defect also. Penetrating injury are commoner in males than in females. The most common cause are the assault injuries, domestic accidents, or sport. The extent of injury is determined by the size of the object, its speed at the time of impact, and its composition. Sharp objects such as knife will cause well-defined laceration of the globe. In the case of flying foreign bodies, it is determined by their kinetic energy, their speed, their size is very important in determining the extent of ocular injury. Whenever you have a penetrating trauma, we don't remove any penetrating foreign bodies. We minimize additional damage, put the patient in PO, give him tetanus prophylaxis, antibiotics, and then refer for repair. This is penetrating eye injury with a gun, with a nail gun through the upper part of the globe. And this is also severe trauma, severe penetrating eye trauma that resulted in protrusion or expulsion of the crystalline lens of the patient. This is another example of penetrating eye injury with where the lens becomes cataractous and there is there is cortical lens matter in the anterior chamber of the patient, secondary to penetrating injury to the anterior capsule of the lens. In certain cases, penetrating eye injury might be associated with the presence of intraocular foreign bodies. Whenever we suspect intraocular foreign bodies, we should do CT scan. We don't do MRI because that intraocular foreign body might be metallic, so we don't do MRI. On CT scan, you can see the location and sometimes the size of the intraocular foreign body. So you can see here that there is an intraocular foreign body, and this is an X-ray where also you can see an intraocular foreign body. Whenever there is intraocular foreign body, especially if it is metallic, we should remove it. Intraocular foreign bodies may lead to a high incidence or they may increase the incidence of infection. Also, metallic foreign bodies, they tend to release metallic ions such as ferrous and copper, and those ions will accumulate in different ocular tissues and cause secondary damage. This is why copper and iron foreign bodies should be removed as soon as we can. Inert foreign bodies such as glass probably may increase the risk of infection, but it's not as urgent as the metallic foreign body in terms of timing of removal. As we talked before, CT will localize the foreign body better than MRI. Antibiotics intravenously, and you should refer to the proper ophthalmic service. Here are additional examples of CT showing intraocular foreign body. This is the sclera, and this is the intraocular foreign body lodging in the sclera. Whenever we have a patient with open globe injury, we should protect the eye and try to prevent secondary damage. Protection is by an eye shield, not an eye patch. So if you have a proper metallic eye shield, you apply it. If you don't, you can use whatever you available. And the commonest example is you cut the plastic or cartoon cups. You cut the base and you just apply it with tape on that eye to protect it further. We should avoid Valsalva maneuver. We don't instill any medications in the eye. Don't remove anything hanging from the eye, and immediate referral to ophthalmology service and preparation for emergency treatment. The most important thing in penetrating ocular trauma is especially for those at risk in the certain occupations اللي وظائفهم بتتطلب انهم يتعرضوا لمخاطر، حدادين، نجارين. دائما لازم ننصحهم انهم يلبسوا protective goggles. يعني their institutions والشركات اللي بيشتغلوا فيها لازم توفر لهم كل وسائل الحماية اللازمة حتى ما يتعرضوا للفورين بوديز، الرننج فورين بوديز او البنتريتنج اي تروما. ياما ناس غيرت وظائفها وانقلبت حياتهم رأسا على عقب بعد التعرض للإصابات بهذا الشكل. Now we come to the last topic, which is trauma to the eyelids and the orbit, including the eyelid lacerations and bony orbital fracture. Eyelid lacerations, we should pay attention when we have patient with eyelid laceration. We should pay attention to the eyelid margin and the involvement in the nasolacrimal drainage system, especially the canaliculi. And don't forget that still we are dealing with the eye. So always with eyelid lacerations, you should rule out intraocular injury, open globe injury. When we repair the eyelids, the eyelid, as you know, composed of multiple layers. Those layers should be opposed correctly to avoid poor lid function. وهذا ممكن ينتج عنه إذا إحنا ما عملنا good repair ممكن ينتج عنه corneal injury and corneal scarring. هذا example of eyelid injury involving the eyelid margin. We should look at the eye and make sure that the eye is intact. After that we plan repair of the eyelid laceration. لما تكون المارجن involved, this is better to be done with an experienced ophthalmologist or a oculoplastic surgeon, because we need to oppose the eyelid margin together first, as shown in this image. And later on we complete the repair of the laceration. إذا ما عملنا هذا الكلام راح ينتج عنا notch في الupper eyelid أو في lower eyelid wherever. هاي النوتش راح تأثر على الفانكشن of the eyelids، وبالتالي بتعرض الكورنيا ل exposure كيراتوباثي بنسميه، ممكن بالنهاية يصير عنا corneal scarring. لذلك الريبير of the eyelid lacerations involving the margin is very important. هلا إذا eyelid laceration involving the medial eyelid, then we suspect canalicular obstruction, and كمان هذا لازم يصير في repair by experienced personnel. نستخدم tube خاص to identify the canaliculus, and then we repair the eyelid laceration to prevent canalicular obstruction afterwards. لما يكون في laceration extensive وفي tissue loss كمان هاي indication انه تعمل referral ل experienced ophthalmology service. Don't forget, you should rule out always eye injury whenever you have lid laceration. ما يغرك منظر الليد laceration ونركز عليه وننسى انه the eye is more important and it needs to be more urgently repaired. Last thing is the bony orbital fracture. The fracture of the هذا بنتج عن البلانت تروما وبصير ناتج عن the increase in the intraorbital pressure that بسبب هاي البلانت تروما واللي بتؤدي ل rupture of one of the orbital walls, mainly the floor and the medial wall, to release that pressure. The fracture of the floor is the most common and called the blowout fracture. Patients with blowout fractures will complain of diplopia, especially in the up gaze, خاصة إذا the floor can involve eyelid swelling after nose blowing, and there might be crepitus of air within the orbit because of the leakage of air from the nasal sinuses, especially in the medial wall fracture into the orbital space. When we examine the patient, we will see that the eye is sunken, so it's enophthalmic. There might be restriction of the eye movement. We may feel an orbital step deformity, suggestive of a displaced fracture, a patch of paresthesia on the inferior orbital rim. When we suspect blowout fracture, we should do a CT scan to identify the extent and degree of type of fracture. هاي example لمريضة عندها blowout fracture after blunt trauma. The eye is enophthalmic. The patient is attempting to look up, but this eye is restricted in the upward movement. وبالتالي هذا بشير لأنه it is entrapped inferiorly. في عندنا entrapment of the eye inferiorly secondary to floor the orbital floor fracture. هذا مثال ايش اللي بيصير. في عندنا تنس بول ممكن تضرب الاوربت، بيزيد عن البريشر في الاوربيتال سبيس، وهذا البريشر should be released somewhere. The weakest point is the floor. So عشان هيك بصير فينا fracture of the floor وبصير فينا entrapment. entrapment ممكن يكون fat, only fat and soft tissue، ممكن يكون involving المسل also. وهذا another example CT scan showing blowout fracture the orbital floor with entrapment of some soft tissue. When we diagnose orbital floor fracture, we should decide whether this needs to be treated or not. So generally speaking, if there is soft tissue entrapment with the diplopia, or the fracture is greater than 1/2 of the orbital floor, or there is significant degree of enophthalmos, so those are indications for repair. Otherwise, the treatment is conservative. What is the prognosis of ocular injury in general? The prognosis is determined by the following factors: the occurrence of infection, the extent of damage to the retina, damage to the lens, resultant corneal scarring, whether the injury involves intraocular foreign bodies or not, and rarely the development of what we call the sympathetic ophthalmia. Just few words about sympathetic ophthalmia. It's an uncommon, devastating condition where the other eye responds with severe inflammatory reaction and loss of vision following extensive injury to the uveal tissue within the eye. عشان هيك في كثير من الأحيان لما يكون severe eye injury and there is no prognosis of visual recovery, it's better to remove that eye in order to lessen the risk of sympathetic ophthalmia. However, sympathetic ophthalmia is an uncommon disorder. Thank you very much.